My name is Katja Sockel. I'm from the University Hospital in Dresden, and I think there are many things going on in the low-risk MDS field. There have been some important advances in the last year, especially the extended approval of luspatercept for virtually all transfusion-dependent low-risk MDS patients, but there's still much to do beyond that. So when we think about what's next in the treatment of low-risk MDS, then we have to consider different issues. The first is the patient selection. So because if we can have the best treatment, but if we choose the wrong patient, the treatment will fail. So in the moment, our treatment or therapeutic strategy is based on the prognostic scoring systems like the IPSS-R and the IPSS-M, which implements clinical data, cytogenetic and molecular data. However, we know that inflammatory changes play a major role in the pathogenesis of MDS. So including this so-called immunome or immunological data might improve our patient selection, especially when we consider anti-inflammatory treatments in MDS. And there might also be metabolic changes which are relevant, especially when we think on IDH inhibitor therapies that might be incorporated in the future prognostic scoring systems. So next, the treatment, can we optimize our current treatment strategy? So when we think on the current therapeutical regimen in low-risk MDS, the most drugs are only approved for transfusion-dependent patients. So if you have a symptomatic anemia but are not transfusion-dependent, you only can get erythropoietin in an approved manner. So the question is whether we really have to wait for transfusion dependency, and that was already addressed in the del(5q) patients. There was a big Sintra-Rev phase 2 trial in the last years, and it is now addressed also for luspatercept in the big phase 3 Elements trial, and we are really looking forward to the results of the study. And there are also some dose optimizing studies underway, which are very important. So especially in luspatercept, we always start with the lowest dose, but maybe it's also reasonable to start with a maximum approved dose for our patients. And there are also some new drugs under investigation. The hot topic in the moment is imetelstat, the telomerase inhibitor, which has recently been approved in the last days in the US by the FDA for patients who have a high transfusion burden. That means more than 5 red blood cell units in 8 weeks. And who are either refractory or relapsed or have a very high EPO level and are therefore either ineligible. So we hope that we will have this drug, also will have access in Europe to this drug, but we will see what the EMA will decide. So there are other drugs under investigation, similar like luspatercept, another activin ligand receptor ligand trap, elritercept, and also anti-inflammatory drugs like canakinumab, an IRAK4 inhibitor, and NLRP3 inhibitors. And there are also new concepts we are thinking about. We already know from high-risk MDS that combination therapy might be an option, and maybe also in the low-risk MDS setting. So EPO and luspatercept target different phases of the erythropoiesis. EPO works more in the early erythropoiesis and luspatercept more in the late stage erythropoiesis. So combining these two drugs might be beneficial for some patients. And we are also thinking about the goal for the treatment in our low-risk MDS patients. So in the moment, our goal is to improve the symptoms and reduce transfusion requirements, but I think we should focus more on disease modification to avoid disease progression, or at least prolong disease progression. And therefore, targeted therapy might be an option, like we already use for del(5q) with lenalidomide. And there are interesting studies with IDH1, IDH2 inhibitors underway. There's a phase 1 study with a STAT3 inhibitor addressing low-risk MDS patients with a STAT3 overexpression. And also imetelstat has shown some disease-modifying activity for especially in patients with an SF3B1 mutation, because patients who responded in this trial had a mutational burden reduction. So, and the last thing which is currently hot discussed is whether we should intervene more early at pre-MDS stages. We know that MDS and AML is a biological continuum rising from clonal hematopoiesis. So maybe if we treat early at the chip or cycles level, we can avoid a manifest disease in the future. There are several studies ongoing with monoclonal antibody canakinumab and also with enacidimab. And at this year's EHA, there will be an interesting presentation on vitamin C supplementation in the late-breaking session. So we are very excited on this data. And I think the future looks bright for our patients. And yes.